again, with double contrast, we're gonna do everything that we did with the single contrast, and we're gonna do the corresponding opposite. So we're gonna do PA oblique, both PA obliques. We're gonna do PA axial, we're gonna do AP axial, both AP obliques. You're not gonna do two laterals, all right? So we're only gonna have one lateral, but everything else we're gonna be duplicating. Also, though, what we're going to do are, we're going to do bilateral decubitus images as well. So, unfortunately, we're going to have to rotate the patient all the way around at least twice. Okay, so we can't get past that. We're going to rotate the patient all the way around at least twice, but you don't want to do more than that. Okay, so all the positioning is going to be the same. One thing I think needs to be pointed out is that, the textbook says that for your obliques that you center away from midline. And the purpose for that is because if I shoot a KUB here, right, can't get lower than that because of the computer, but if I shoot a KUB here and I oblique up into a 35, 45 degree oblique, then naturally that's going to put my centering, if I leave it at midline, it's going to put the centering towards the side closest to the image receptor. And what that's going to do is potentially miss the anatomy on the elevated side, right? So what we're going to do is we're going to off-center just an inch or two towards the elevated side. And it's easy to find whenever we shoot PA obliques because you've got the spine, right? For the AP obliques, it's a little bit more difficult, but it's not all that tough. If you just go anterior to the ASIS, you should get it just a couple of inches anterior to the elevated ASIS. So I did go to my office and I got a more cooperative colon. This is a high voltage cable. I can pass it around and you can kind of see the elements of the cable. It's got a lot of insulation. The wire itself is not all that big, right? Because we're using very high voltage, right? Remember, high voltage, low amperage, high voltage. So since we're using high kVp, we don't need a big wire, but we've got a tremendous amount of insulation. I'm telling you this for a purpose. Around that insulation, we've also got this wire mesh protector. Okay, so at some point in your career, you're going to walk in, and this outermost plastic covering is going to be nicked. Okay, you're going to see wire underneath it, and your immediate thought is, that's high voltage passing through that wire. And it's not. What you're seeing is a protective mesh, and I'll pass this around so you can see it, but what you're seeing is a protective mesh to keep you from damaging the insulation and thereby getting to the actual wire. Okay, so that's just a protective thing. Now, if you go through that, you need to call maintenance and have them replace the wire. So I like to use this as a demonstration of colon because I can just kind of hold it up and it naturally orients itself kind of like a colon. Okay, so just to review, our AP obliques, LPO is going to show the right, and the RPO is going to show the left, right? So it's always going to, correct, it's always going to be on the elevated side, right? For your AP obliques. For our PA obliques, it would seem that it would be kind of, since we're, an LPO corresponds to a RAO, that we would see the side closest to the image receptor, right? Correct. So the LAO is going to show us the splenic flexure, right? All right, but it's more complicated than that. Okay, so what are we doing with air contrast? It's right there in the name. We're going to have contrast, which is not just barium, but air, right? So what are we looking for? Mucosal lining, anything in mucosal lining, right? So what we want to see is we want to see two things. We want to, and the reason we're going to do PA and AP is we're going to want to see the colon full of barium, and we're going to want to see the colon full of air. Okay, so now you got to think gravity. So which is heavier, barium or air?
Barium.
barium by a long shot, right? So then we got to consider where we're going to see the barium, where we're going to see the air in each one of these images, right? So on our AP obliques then, what we're going to see in the LPO, we're still going to see the elevated side, but what's it going to be full of? Is it going to be full of barium or air? Air, correct. So now we're going to see air specifically. And on the PA obliques, we're going to see in the side of interest, it's going to be full of barium, correct. So the rules remain the same. You know, on the AP obliques, you're still going to see the elevated side. On PA obliques, you're going to see the side closest to the image receptor. Okay? So those rules remain the same. It's just what's going to be in those. On the AP, it's going to be air. On the PA, it's going to be barium. Okay? On the AP, where is the barium going to be if our colon comes up and it goes anterior and across? Where is the barium most likely going to be? Ascending and descending colons. Where is the air going to be? Transverse colon. PA? Just reverse that. Air is going to be in the in the sides, exactly. Ascending, descending colon. And then the barium is going to be in the transverse colon. Okay? Now, probably the most complicated thing on this test is not that. It's going to be our decubitus. So we're going to shoot the decubitus, and we've got to not only consider gravity, but we have to consider gravity in each side. Does that make sense? So with the patient laying on their side, so this patient in this case, I'll make it like this, is, and it doesn't matter if you shoot AP or PA. It really does not matter. I recommend that you shoot with the tube orientation from the same side. So naturally in that case, what you're going to shoot is one AP and one PA. And it doesn't matter. You know, if you feel more comfortable moving the tube over, you know, have fun, whatever. But I'm going to shoot one AP and one PA so I don't have to move the tube. Makes it a little more efficient. All right, so I've got this patient laying on the left-hand side. So what I'm going to see is I'm going to see barium in the lower side of both the ascending and descending colon, which means it's going to be in the lateral side of the descending colon, and on the medial side, I had to think it through while I was medial side of the ascending colon. Right. All right, and then you flip them over. Now you're in a right lateral decubitus. Again, horizontal central right. The barium is going to be in the lateral side of the ascending colon, medial side of the descending colon. Okay, so we're going to walk through it again. Where's the air going to be? So in the left lateral decubitus, air is going to be in the medial side of the descending colon and the lateral side of the ascending colon. So flip them back over this way. So now we're in a right lateral. The air is going to be in the medial side of the ascending colon, lateral side of the descending colon. Okay? Now think Bouchon. So first few pages of Bouchon. What's that little graphic? Talks about an iceberg in Antarctica. The penguin thing, yeah. So do you need all those little penguins? What can you do in the test? Are you taking the test? You got a question that pops up on the test. It says, where is the barium going to be on a... Where's barium going to be on a left lateral decubitus? What are you going to do? Bingo! Then you go, right? Where's barium going to be? Right? Okay? So just pick out instead of memorizing each one of those, just, understand your gravity and what's gonna go up, what's gonna go down. Position yourself. Again, y'all are second semester students. You've embarrassed yourself in front of each other at least once, right? So that ice is broken, right? So, just lean over in your chair. Everybody is going to know what you're doing. And if one person does it, the rest of the class will do it. It's just, be a trendsetter. Be that person that puts everybody else at ease. All right? So, let's look at some images, kind of pick out what we're looking at. Okay. So, we already looked at the AP. It's air contrast, so we can see the polyps and all that kind of stuff. AP and PA are really going to look similar. If you're looking on your lab test, one of the things that you want to look for is, the bony structure. I mean, does that pelvis look normal? Maybe if you're a bird, right? They got a weird looking pelvis, but for a human, does that look normal? It's pretty symmetric side to side, right? So what's the only thing that it could be? It says right there, either AP or PA axial, right? So then if it's only barium in the colon, it's probably going to be your AP axial. If it's, if you got air contrast, that could be AP or it could be PA axial. I don't know. Tell the difference between them? Not really. They're so distorted. It's tough to tell the difference between them. And chances are on the test, if you put AP/PA axial, they're probably going to give that to you. All right. So what do we have here? I really should have these just kind of, fade in, after I click, but can you kind of see? We've got the splenic flexure over here. We don't see the top of the splenic flexure. Is that a problem? Is it? It's RAO. What are we looking for on RAO? Right side. Do we see the right side? Yeah. So is this a repeat? No. If we position this way for the LAO, might it be a repeat? So yeah, could be. Okay. So, before you go back in and blast the patient again, consider, I'd be hard pressed. I mean, technically, yeah, you don't see the entire splenic flexure on that. I'd have to, I've probably already drained the patient after this. So, you could go back and repeat that if you wanted to, but I don't, unless there was specific pathology that the radiologist was worried about up in there, probably would not. So the lateral, your central ray is going to be to the midline of the patient, mid-coronary plane level of the ASIS. So this is what we're going to see. We've still got the enema tip in the patient, so this is probably not, especially considering we've got some air in there, it's probably not cross-stable. So the patient's rolled up on their side, enema tip still in. We see the retrorectal space, the area right behind the rectum. So again, AP axial, you just, without some sort of marker that, showing you whether it's AP or PA axial, you're just not going to see it. So some pathologies, all right, so this is not a pathology that is included in this slideshow, but some of your pathologies, the patient will lose their haustral markings, completely lose their haustral markings. And sometimes that's because of overuse of laxatives. So there are appropriate times to overuse laxatives. My ex-grandmother-in-law, okay, you gotta follow that. She had hepatitis A from way back when, and she was in liver failure for a long time. They had her on massive doses of laxatives just to try to keep her clear, right? And so her colon would look something like That's what we refer to as stovepipe colon, because it has no hostile markings at all. All right, so LPO position, what are we looking for LPO? Which side are we interested in seeing? Elevated, upside, downside? Upside, elevated, right. So then we've got our hepatic flexure there, completely open. Our splenic flexure is just a mess. AP, look at this guy, he's got a sigmoid transverse colon. And then our decubitus, let's get to the decubitus. Okay, so here's our decubitus, right lateral. We can tell this is right lateral for a number of different reasons. We've got the left marker here, which would indicate the bottom side, would be the right side. If you're doing your decubitus, a couple of things. One is you may have to build your patient up in order to make sure that you don't project a downside colon into the table like what they've got here. Or you can utilize the divergent central ray, and this is not the best radiation protection for the patient, but you're really exposing more of the table than what you are the patient in this case. But you can center a little bit lower, putting your central ray a little bit lower into the patient, and what that would do is take the rest of the anatomy and project it upwards instead of centering in the center, projecting it, the divergent central ray projecting the downside colon off of the image receptor. Okay, so I'm not 100% endorsing doing that, but if you've got a patient that you just can't build up, you can't put them on, let's say you've got an asthenic, fragile patient that you just can't move, then that would be an option, right? So what we're going to see here then is, again, in our right lateral decubitus, we can tell it's right lateral for two reasons. One is the marker. The other is the height of the hepatic flexure. The hepatic flexure is going to be lower. So we're going to see barium in the downside of the ascending colon. So on the lateral side of the ascending colon, medial side of the descending colon. Air in the lateral side of the descending colon, medial side of the ascending colon. And that would be just the exact opposite. And again, we can tell that this is a left lateral because that's your splenic flexure really high. So our pathologies, of course there's a comprehensive list of pathologies, first part of the chapter. These are the ones we talk about most of the time. Intussusception is a condition in adults. It's usually secondary to something else. A patient has a cancer, let's say, and one portion of the colon will slide into the other portion of the colon. There's some graphics in the video that I did at home, pictures out of Bontrager's. Some of the things in Bontrager's I like, some of the things in Merrill's I like. But some of the pictures in Bontrager show a drawing, essentially, of what this looks like. But basically what you've got is a portion of the colon slides inside of another portion of the colon. That's intussusception. Secondary to a different pathology in adults. In children, it's idiopathic, meaning we don't know why it happened. But if we can get that kid in quickly enough, then they can do a barium enema or gastrograph enema, some sort of enema, and even squeeze the bag a little bit to increase the pressure some, and it will fix it. And that's what we would refer to as reducing it. Reduction sounds like smaller, right? Intussusception sounds like smaller, but in this case, it's exactly the opposite. You're reducing that intussusception, you're fixing it, it stretches it back out, and a patient can go home. The problem is that the blood supply can be compromised, and if it's compromised for too long, that valve's going to die. So let's say you got a water hose, and you don't have a tip on the water hose where you can turn the water on and off, right? How do you make the water stop? Pinch it over, right? You just pinch it over. Now imagine with intussusception, what you've got is, let me bring this one up. Imagine with intussusception, what you've got is a valve going this way, and then it makes a turn and it goes that way, and then it makes another turn and it goes that way. So now your water hose is pinched off twice, right? No blood is going through there. So if they get the patient in there quickly enough and they, before that valve dies, and they get that reduced, they get it stretched back out, then the patient's going to be fine. Idiopathic in kids, secondary, usually the cancer in adults. Volvulus is where the valve twists for whatever reason. And this is really pretty wild. If you ever see an abdominal surgery, open abdominal surgery, they've got the drapes on the patient. They'll take the bowel out of the patient and just set it on the drapes, right? They get ready to sew the patient up, and they just scoop it all back in and go to sewing. And a bowel finds its own place. You would think that this would be secondary to some sort of open surgery, and it's not. It just happens. Why, I don't know. But anyway, it's twisting of the bowel. So imagine a clown making the balloon animals, right? So if they want to push the air to one end of the balloon and they want it to stay there, what do? Twist it. They twist it. Same thing. All right, so cancer has a specific look, and we'll take a look at that. And then diverticular we already looked at. Intussusception has a characteristic look sometimes. And it kind of looks like a coiled spring, like a mattress spring. If you've ever seen an old-timey mattress spring, kind of looks like that. Volvulus, because it comes to a sharp point in two different places. It kind of looks like a bird beak. We call it the bird beak sign, coiled spring sign. And then with cancer, if it's extensive, then what happens is the cancer comes into the lumen, into the hole into the inside diameter of the bowel from all different directions, and it has a characteristic look to it. It's an adenocarcinoma, but we just refer to it as an apple core lesion because it looks like an eaten apple core. All right. So intussusception, you kind of see the coiled spring look appearance of that. It almost looks like a small bowel. Volvulus, okay, so that bird's beak is kind of rounded off. And I thought I had a good apple core lesion on there. Let me see if I can find one real quick. Not the best, but you can kind of see a little bit. See how it's fat at the top, skinny in the middle. That one's probably one of the better ones, because nobody ever eats the very end of it. Why? I don't really know, but you tend to eat straight across the middle. Like that. Why doesn't anybody ever eat these parts? Those aren't bad. But anyway, that's what apple core lesion looks like. Is kind of like that. Okay. Any questions?